having been around for 25 years, our company, I would like to share a little bit the history of deployment of EMRs and how low the adoption rate is today. So if you look at the last 20 years, we have been talking about some sort of EMR. And first we call it, at the time we started, we call it clinical information systems because nobody else was doing clinical applications at the time. Then it was called CPR, EPR, electronic patient record. It was called EMR, EHR, and all kinds of different names. So we have been talking about this for almost 20 years. But the reality is only 8% of the hospitals today have a true EMR. So why is it that the adoption rate is so low? And what makes us think that now we're going to be able to do this in the next 24 to 36 months and not be penalized? So I want to bring some of the historic events, so at least we try to learn from what happened in the past and maybe look at what the approach should be to be able to accomplish what we need to accomplish. So, and I promise only 7 minutes. So keep in mind, meaningful use reimbursement is reimbursement to cover the automation gaps that she was mentioning, Judy was mentioning. This is not a cash for clunkers program where you're going to replace everything you have. So I just want to start with that statement. So if we, which by the way it failed, that program, so if you're planning to get money for clunkers, it's not going to work. So basically if you look at the first, the 1990s, that decade, basically, we started talking about EMR, but the reality is that most of the healthcare organizations needed to install core components. And by core components, I mean iHT, lab, radiology, pharmacy, all the systems that at the time there were the companies like HBO, TDS at the time, SMS, et cetera, et cetera. So most of the money, there was a lot of money spent on core components. By the end of the 1990s, we were ready for clinical implementations. We were ready for an EMR. And actually, most of you as healthcare organizations, you were already looking for EMRs. And basically what happened is just when you were ready to implement the EMRs, somebody said that there's going to be a Y2K bug and everything was going to explode. And then all the money that you spent for that whole decade was a waste and you needed to buy new systems. Basically, the vendors didn't tell you, I only have to make a little tweak on the system and I can be compliant, but the reality is they wanted to get the money all over again. So what happened at the time, organizations were ready to do best of breed, but because of the rush of having to implement systems in 12 months, they had to go with one vendor solution. Of course, the reality is that it didn't take 12 months. It took 5 to 7 years. The Y2K issue was not a big deal. So 7 years later, around 2007, people got to the same problem where now they had core systems, but they didn't have clinical applications. They looked at their partners and they realized that there is an automation gap. I still don't cover my clinical applications. So then at that point, healthcare organizations started saying, we're going to replace the systems all over again. Fortunately, recession came. Because recession, even though it was bad for us personally, it was very good because it made us rethink about the way we spend money in healthcare. And just when there is no funding available, all of a sudden the government started talking about meaningful use. Meaningful use, of course, to cover the automation gaps. So the message that I want to convey here is that the approach, if we continue with the approach that we have over the last 15 or 20 years, not only we're not going to meet the deadlines, we're all going to be penalized in 2015 when we don't implement the systems. So what we need to do is we have to look at what we have. All the money that you already spent, it's good. You have good core systems. It's just that those core systems are not going to fill up the gaps that you have within the organization. But of course, politically, you need to start enforcing that those vendors, those partners that you have, they need to start optimizing their systems so you can start meeting the requirements between 2011 and 2013. And then with that money, you need to start looking at how can I get to the requirements of 2013, but definitely with other vendors. And those partners that you have, they need to open up their systems because they're not going to develop things fast enough to be able to cover those gaps. So again, optimize what you have. You probably already have enough systems to cover the requirements between 11 and 13, but you need to start immediately looking at high acuity because those are the automation gaps. It's what do you do on the emergency departments, ICUs, operating rooms, step-down areas. Of course, that's what we do, but I'm not here to talk about a Clinicomp. But the reality is that's where you're going to find that there is funding. And of course, the funding, if you talk about $4 to $7 million, when we were talking about money is not enough. It's not enough if you take that approach and you cover only the holes. If you try to replace everything, money is not enough. And then, of course, it was very funny when we already hear that vendors already have a meaningful use release. They don't even know what that means, but we all have a new release for meaningful use. So in any case, the reality is we can only meet that if you leverage from what you already spent, optimize those systems. What you have from Epic, Cerner, Meditech, those systems are not bad. You partner with them, they will be able to get you through the first 2 years. But for the rest, you have to look at emerging technologies, you have to look at best of class, best of suite, best of breed vendors that can cover those holes.